Thank you all for coming. Thank you also for our virtual attendees. My name is Brenly Fletter. I'm a nurse, and I work at the Tazewell County Health Department as a family case manager managing the adverse pregnancy outcome program. First of all, if you are attending virtually as a group, go ahead and send us a sign-in sheet of those in your group so we know who is all watching. And at the end of today's meeting, we're going to add an evaluation link to the chat. So nursing CEUs and the certificate of attendance, that'll be provided to all paid registrants. You'll find that being emailed to you. And if you haven't registered yet and you haven't paid yet, that's no problem at all. Just email Sarah Williams and we'll throw her email in the chat. And also a recording of today's presentation is going to be emailed to everybody who's participating. So in March of 2022, the Illinois Department of Public Health added cannabis positive neonatal or maternal toxicology or disclosure by the mother to the definition for high-risk infant follow-up. So medical facilities are required by law to report this as an adverse pregnancy outcome. Those go to the state. They are promptly kicked back to the local health departments. And at Tazewell County Health Department, we have seen a 36% increase in referrals this past year. I'm sure that's the case for many of you too. The number of referrals that we're receiving for cannabis exposure, that's only part of our concern. We're finding that our parents aren't always aware of the dangers of using cannabis products during their pregnancy and during lactation. They see the benefits of decreasing nausea, maybe helping out with anxiety, and they're often surprised when we notify them that their child is now available for high-risk infant follow-up. They're also not aware that the testing has occurred. They report sometimes mixed messaging from providers. So a brief survey of the literature provides some concerning data. Studies have indicated a relatively high prevalence and frequency of marijuana use in pregnant women. There was a cohort of women studied for their nausea and vomiting symptoms during pregnancy. Marijuana use was elevated every single year from 2009 all the way up to 2016. There was another study, this one took place in Colorado at dispensaries, and it found that 69% of Colorado dispensaries were suggesting cannabis use for nausea and vomiting in pregnancy, and another 36% were endorsing the safety of marijuana during pregnancy. But the data is consistent across all kinds of studies. The use of marijuana is increasing. So what we're seeing is being shown in the data as well. And its use is increasing throughout the years. I would like to share a story straight out of Tazewell County. There was a woman who went to the ER. She had dehydration, hyperemesis, and while she was there, an ER nurse recommended that she used marijuana to help her with her symptoms, and she referred to it as a plant-based medicine. So this woman talked to her OB about this, and who approved. So she also had an anxiety disorder at the time, and the thinking was that maybe the marijuana would help with that as well. So fast forward, this mom is now in the hospital and she has delivered a term healthy baby, but a positive toxicology report for marijuana triggered a social worker to show up at her bedside. Yeah. So the social worker is talking with her and she says she gets to just tell her story of the hyperemesis, going to the dispensary, and the fact that her OB provider was on board with this. She explained also that she could have taken some of the traditional methods, Zofran or something like that, but the idea of taking a plant-based medicine just seemed more healthy to her. The social worker listened and accepted that explanation as quite reasonable and ended the conversation there. So now 2 weeks later, she's recovering at home, she's postpartum, and she gets a voicemail from her local health department saying that we got a referral from her birth hospital saying that her child is now qualified for the high-risk infant follow-up program. to make it even more difficult, she got that message on a Friday. We didn't get back to her. She stewed on it over the weekend. And on Monday, when she finally was able to talk with a nurse, her question was really compelling. She asked, "Why are you guys calling me when my OB and that ER nurse had no problem with the marijuana?" It's a good question. And it's one of the questions that we really want to grapple with today, right? The goal is for all of us here to come together and work together to ensure that there is consistent messaging going out to our women in our community, that we're understanding what's happening both in the literature and what's happening right here in our hometown. So today we're going to have the opportunity to hear from a lot of different viewpoints, people who have a variety of perspectives. Each voice is representing their own experiences, their own research, and their own viewpoint of what they're seeing. So we're just seeing these as our first steps towards our combined effort to care well for our community. So right now I would like to introduce Julie Herzog.
Good afternoon. My name is Julie Herzog. I'm from the Tazewell County Health Department. I lead the All Our Kids Early Childhood Network. You'll hear a little bit about some of our roles within Dr. Shallat's presentation later, but right now I'm going to introduce our speaker for first keynote. Dr. Erin Weiner is a board-certified counseling psychologist and master addiction counselor, currently practicing in the northwest suburbs of Chicago. He is a national speaker, former health educator administrator, and current president of the Society of Addiction Psychology. His perspectives come from his years of experience working with veterans in the VA hospital system, directing addiction strategy from hospitals in Chicago, and his experiences in private practice. I'll let Dr. Weiner take it over.
All right, thank you. And hopefully everybody can see me. Definitely someone flag me down if that's not the case. I'm going to make myself big here. All right. Okay, so I really appreciate everybody bearing with the fact that I can't be there in person, but really honored at the opportunity to be able to speak to you today about this. This is a topic that is something that I personally am very passionate about. It's something where, or I should say specifically as an addiction psychologist, I care very much about misinformation, because I think that addiction and substance use over the years has really been defined by that in many cases. And what we're seeing in regards to marijuana or cannabis, and we'll define terms in just a second, is something very similar, where there's a lot of misinformation, a lot of disinformation. I think that we kicked things off today really highlighting that, and actually we'll have a few quotes from that study that looked at the dispensary in Colorado as we go along today. But for the first talk, the one that I'm doing, really what we'll get into is more of the basics around marijuana and cannabis, what it is, what it's not, how it interacts in more of a social, psychological, and behavioral level with pregnancy. And then our co-presenter, Dr. Shallat, she'll be getting into more of the more medical side of things. So to get us started here, I'll bring us over to the slides. What I'd like you to do, actually, I know this is a dangerous suggestion, but if you could please pull out your phones or open up a tab on your computer and go to menti.com. You can see it there in the bottom right. Part of how I'll be able to interact with you, despite not being there, is using this service. And actually, we'll start the day with a quick question to get all of our brains in the right spot. But if you go to menti.com, enter that code in the bottom right, 7909538. It should bring you up to this screen, which I'll put on screen right now. It says live polling. And I'll actually advance us one further here so that we can see that number again. And what you can do through here is actually add in your questions as you go along. So I'll be able to look at them at the end and put them on the screen, as well as we'll use this again a little bit later. But here's my question for you. How much do you think the following groups would agree with the statement, marijuana or THC use poses significant risks to a healthy pregnancy? The first group being healthcare providers such as yourself, the second being pregnant mothers who do not use cannabis products, and the third being pregnant mothers who do use cannabis products. So how risky do you think they think it will be. Strongly agree means they think it's very risky. Strongly disagree would be on the other end. I'm just curious to get folks who are both online. I think there's about 60 folks attending online. Please feel free to chip in. Folks in the room do the same. This is at least one forum where we can all get together. And part of the reason why I'm kicking us off with this particular question is that here, I'll take my head out from, oh, actually, I'm not blocking anything, is that there's a gap. There's definitely a knowledge gap. And actually part of what we'll look at when we look at the studies that have examined what do current cannabis users think about it versus those that don't, is that this trend that we're seeing with the responses as they're coming in, being that the pregnant mothers who use it really tend to minimize, is definitely what we're seeing. To be honest with you, I'm a little surprised to see that folks are feeling like healthcare providers actually don't think it's as risky as pregnant mothers. Maybe that has something to do with definitely wanting your baby to be as healthy as possible. But generally speaking, there is this gap between what we see in medical journals and the public, and that's what we're going to be trying to bridge today. So thank you everybody for getting on to Menti. Again, you can see a button on there to ask a question. Feel free to throw them on as we go along today, because we will be covering a lot of material. Then at the end, we'll swing back around and we'll be trying to put together questions that you've entered on there, ones that folks online might have put into the chat. And then also the mic is live enough to just ask it in the room. And so I think we'll be able to facilitate live questions as well. So, all right, that being said though, let's dive in, because there is a lot to talk about. 90 minutes goes so fast on a subject like this. So let's go ahead and get going. One last piece of housekeeping. My email's there in the bottom left, aaron@weinerphd.com. If you have any questions at all about what we covered today, or you'd like the original source, I am happy to send it to you. I try to be very transparent about where I get my information from. So if you have questions, just drop me a line. I'll be happy to answer them. So let's start with the basics about what cannabis actually is. Cannabis is a plant category with about 500 different compounds, 100 different cannabinoids. The two we talk about most regularly are THC and CBD. Now, I think it's important at the get-go here to really clearly define our terms, because this is a place where a lot of us get confused. Like, is it cannabis? Is it marijuana? What's THC? How does this all interweave? So cannabis is an umbrella term. It covers a family of plants. One of the plants in that family is hemp. Hemp, by definition, it tends to be low in THC, or it has to be, actually less than 0.3% THC by volume, and tends to also be very high in CBD, or cannabidiol. CBD is a cannabinoid. THC is a cannabinoid. THC is the cannabinoid that gets you high and has addictive properties, and that we'll be talking about quite a lot today. CBD is it is also a cannabinoid, but it acts through some different chemical pathways. Again, we'll talk a little bit more about that. But it's not addictive, it doesn't get you intoxicated, and it's an anti-inflammatory, essentially, and also a really good placebo, as we're finding out. We'll talk about what the research says about what it can actually do for folks versus what it's purported to do. But CBD, generally speaking, both for the general population and in the OBGYN space, is not as much of a substance as concern. Marijuana is a cannabis plant that tends to be high in THC and low in CBD. And so as we go through the presentation today, I'll probably be picking my words based on specifically what it is that we are concerned about. There's a push within the industry actually to move away from the word marijuana, because that's associated with quote unquote stoner culture from like the 60s and 70s, whereas cannabis, they've done a very good job of having that word make people think about health, of natural remedies, of plant-based solutions, things like that. They're trying to grow their user base and appeal to a broader audience. But at the time being, marijuana is a specific term that we use to describe a specific sort of plant. It also is the word, for example, that the Marijuana Policy Project uses, that all of our legislation uses, that NORML uses in the names of the organizations. So I think being accurate is important. But when we talk about what's the difference between cannabis, marijuana, cannabinoids, hemp, that's how we define these terms. So Specifically, though, for THC, THC binds to CB1 receptors in the brain. And if you look at where those receptors are located, you can see why when someone uses marijuana, it has the effect on them that it does. You've got the nausea and vomiting suppression, which is why it's used sometimes for cancer patients, folks who are undergoing chemo. The motor impairment here, higher cognitive function impairment there, appetite stimulation from the hypothalamus, learning, memory, and stress modulation, and then some of the pain-sparing effects coming from the spinal cord. I don't think we're going too far into the pain side of things specifically today, but it's kind of hit and miss there actually as well. But that's where the CB1 receptors lie. However, it is the most used recreational substance right now behind our other two federally legal drugs, alcohol and tobacco. And as was mentioned in the opening remarks, we've seen this increase in pregnant women in particular. This is the most recent data that I was able to find, short of one study that looks at COVID that we'll get to a little bit later. But there's actually been a doubling of cannabis and specifically marijuana use amongst pregnant women and non-pregnant women for that matter. There's been a great increase between 2002, 2003, and now as the industry has kicked in. But of course, we care very much about pregnant women because, as has been mentioned, it does absolutely impact the fetus, and Dr. Shallat will talk a lot more about that during her talk. I think it's at least a little bit heartening that we do see a decrease in the second and third trimester, but at the same time, we're still over 2%, which is a lot more ideally than you'd want it to be for something that clearly seems to be a teratogen. But there's a number of routes of ways to intake this product. The classic way would be smoking it. So you've got joints and blunts for that. Also bongs where the smoke is filtered up through water. But you can also vape it. And this is particularly problematic because the most harmful formulation of this drug, the concentrates, also known as, if someone is dabbing or wax, shatter, butter, etc., these concentrates it used to be really actually cumbersome and difficult to use. You had to use a device that looked like this, where you use a modified bong, something called a nail, and a butane torch actually to heat it up. That's the concentrate, that orange bit down there in the bottom. And that was pretty inconvenient. So when you compare it to this, where vape pens are so easily available right now, so easy to use compared to this modified bong, all of a sudden you've got this delivery method, which is unfortunately very trendy right now amongst young people and makes it a lot easier to use these really intensely potent products. And then, of course, you also have edibles, which again tend to appeal more towards the young. I think we'll come back to this more a little bit later, but even in our state where you can't directly riff off of other products like you're seeing here, we've got baked goods, we've got lollipops, we've certainly got gummies. If you haven't been to a dispensary's webpage, I highly suggest it, or if you haven't gone to a dispensary just to see what's going on in there and how it's marketed and how it's viewed, I think it's very educational to do that, just to check out how it's being done these days. But there also is this high variability and then also change in the concentration of products, which again is directly related to the danger to both the fetus and in terms of also just the adult and the impact on the mother. The more THC that someone is taking in, generally the worse outcomes that you're looking for, or the higher the risk of some sort of adverse event. And what we've seen, again, as this industry started ramping up, is that the THC content has been bred higher and higher and higher in marijuana plants. Back in the mid-90s, and even as early as back at Woodstock, the average THC concentration, that's this blue line here, was about 3 to 4%. And it's just been creeping up and up and up and up and up, to the point now where, if you look at this study from 2020 that examined recreational markets across the United States, you can see that virtually nothing is being sold right now under 15% THC, very small proportion of what's being sold in dispensaries. The over 15% THC category are the green parts of all these pie graphs. And what they found in the study from a couple of years back was that the states that had just a medical program had an average of 19.2% potency, and then recreational offered 21.5%. And so a couple points here that are really important to make. The first is that today's marijuana and THC products are not the same as they were before. One joint of an average THC content joint from one of our dispensaries right now is like lighting up 7 joints from the mid-90s and smoking them all at the same time. So it's a very different sort of thing. The second is, it's really important to acknowledge there's no difference actually between medical marijuana and recreational marijuana, just like there's no difference between like fun Percocet and Percocet. It's all the same stuff. In our state, even before we had a recreational program, it was still the same stuff. The only difference now is the level of taxes that people pay when they go into a dispensary. If they have a medical card, they're paying less for the same product, but it is still the same product. Now, we have to note that THC is an addictive substance, and this is something that has been shockingly misunderstood to me. And I say shocking because it's actually the second most common substance that we treat in rehab programs, right behind alcohol. It's easily number 2. And if you ask people who are there for it, they will absolutely say, yeah, there's physical withdrawal from this. There are cravings. And we've actually known this for decades. This is one of the seminal studies back from 2004 that put a lot of, it's a literature review. It's in the DSM-5 TR. And what the stats tell us is that about 1 in 10 people who regularly uses it, and actually 25 to 50% of daily users, have a cannabis use disorder. I think part of the confusion around this is that it's addictive more like alcohol is addictive than something like, say, heroin might be addictive, where it's not like you're going to use it once and then all of a sudden be like, oh yeah, like this is, I have to use more, I have to use more. It becomes part of your lifestyle. It becomes very ingrained into maybe how you socialize, how you relax. And just like most people who use alcohol don't have an alcohol use disorder, by the same token, most people who use marijuana do not have a cannabis use disorder, but a certain percentage do. And particularly when we're talking about, again, general population, but pregnant mothers as well, it's something we've got to be aware of, and we definitely don't want to undersell just because it might serve someone's, say, their own self-justification, saying that they can stop whenever they want to, when in fact that's really not the way it normally, or the way it can go, at the very least. So let's define medical marijuana for a second, because this is another one of these intersections where it can sometimes get tricky with patients, where they're saying, oh, like I have a card, I'm using it for medical reasons. And understanding this construct, what it is, what it's not, can be really useful. So medical marijuana right now, it's in 39 states, but this is not something that's approved by the FDA, nor is it prescribed or dispensed like medicine. And there are actually drugs and companies that have gone through the process that we have to make claims about products and then offer them up as what we would generally call medicine. You know, the technical name is pharmaceuticals, but we're invoking the word medical in this instance. We've had Marinol for years. That's a synthetic THC product, essentially, dronabinol. Epidiolex is FDA approved. That's down there on the bottom left. That is a plant-based CBD medicine for a certain type of epileptic disorder. And that's one of those misconceptions, actually. It's not marijuana that's good for seizures, it's CBD that's good for seizures. You don't actually have to have any THC to get a benefit. That's why it's not in the FDA-approved drug for this. And actually, Sativex, this is a drug that's been approved overseas. It's a very low potency 1-to-1 THC to CBD oral spray for multiple sclerosis spasticity. It's like, say that 5 times fast, right? But if you look at the dosage, it's 2.7 milligrams of delta-9 THC. That's the specific type of THC that's in marijuana, and 2.5 milligrams of cannabidiol. Very low. And actually, when you look at the indications for what sort of concentrations you should take if you're looking to have some sort of therapeutic effect, it's very low. And an average joint, if someone was to smoke an average joint of recreational marijuana right now, they're probably going to get about 35 to 40 milligrams of THC. So way more than even if someone was taking this in more of a therapeutic way, what a responsible prescriber is the wrong word, but like a responsible medical oversight what it would look like. So it's a heck of a lot more. Quick note as well. So Sativex right now is in phase 3 clinical trials, and they released their first set of data, and it didn't work, actually. They've got 2 more trials going on right now, but this is an example of what it looks like to play by the rules and to actually make sure that a product works for what you say that it does, really research the adverse effects, so on and so forth. What we have is something very, very different. So, of course, like some people are self-medicating right now because we have a recreational program, but because a lot of people, again, have it in their mind that this is a therapeutic or a medical, like plant-based therapeutic product, I think it's important to recognize what this program was that put these ideas in folks' head. The way this worked was that you had a physician state that you had a condition that qualified you, not actually prescribing a cannabinoid or a plant-based cannabis product, because again, we don't actually have evidence that that works in most cases. And so you get your certification and then you go to the dispensary, you can get whatever you want once you're there. And remember, in those environments, the vast majority of what's being sold is really strong, potent stuff. So it doesn't matter necessarily if you should like start at 2.5 milligrams and slowly titrate up, or if you should be getting one of those 1-to-1 ratios. You could go in there and get like a 90% pure concentrate and go vape it. You know, there was nothing to stop folks from doing that. And certainly there's nothing to stop them from doing it now. But that's not generally when we think of like medicine and invoking that term and creating this public health understanding that this is like a natural medicinal. That's not usually how we think about medicine. This would be like the equivalent of you going to your doctor for a sore throat and them saying, okay, I'm going to say that you've got strep throat, and then you take your strep throat card certifying that you can have antibiotics to Walgreens or CVS or something, and you walk in and they're like, great, you've got your card. What do you want? Cephalexin, azithromycin, doxycycline, completely up to you. How much do you take? Up to you. How do you take it? Well, you can rub it on your skin. You could light it on fire and smoke it. You could digest it. Like that. That's the model that we had. And so when we talk about medicine and invoking that term, it's something that we've got to be really careful about, particularly if there's people who have either been self-medicating by going the recreational route, or not necessarily seeing a specialist for a condition where perhaps they could actually have an FDA-approved route instead. It really wasn't physicians who were pushing for this. This is medicine via legislature as opposed to medicine via an actual board. So now what we actually have, though, are some therapeutic uses for certain cannabinoids. And this is what we know right now from the research. And you can look at the meta-analyses and literature reviews on this, and it will tell you something similar. That we know that it's used for appetite stimulation, nausea suppression, that's THC specifically. CBD is helpful for epilepsy. Cannabinoids like Sativex, for example, have been tested for MS spasticity, and those tests are still ongoing. It can be good for insomnia, but again, it hasn't been studied with a smoked or plant-based product, only CBD and THC, because of course, when you get into plants and plant-based products, there's this question of like, what strain are you using? How deep are you inhaling? How long are you holding it in your lungs? It's really hard to control. So that's why generally people just look at a single active ingredient at a time. But for insomnia, that's either CBD only or low dose 1-to-1 CBD THC. There's some mixed evidence for pain, but there are definitely some studies that show that it's useful for some sorts of pain. And I'd encourage you to look at the National Academy of Sciences, Engineering, and Medicine's report on this for a really thorough literature review. But that's it. Those 6 conditions. But here in Illinois, it's approved by the legislature for 51 different conditions, and here they are. It's worth mentioning, I don't know how closely you guys were following this. I know I followed it very closely, that this used to be 40 for a very long time. And then when we legalized recreational marijuana, it was increased to 51 through the legislature. And part of the reason why that happened was that the marijuana industry had been trying to get it added, these extra 11 conditions added for a long time, and they'd been petitioning the Illinois Department of Public Health. And the medical director looked at it and basically said, there's no evidence to back up the claims that this actually helps. Like there's no peer-reviewed medical research, and had turned them down. So then they went around in this legislative back way and got it added in that fashion. So again, that's kind of like when we talk about people using the word medicine or thinking about it therapeutically, it's not to say that it can't be used in some ways, but at the same time, as healthcare providers, I know that I am very strongly loyal to evidence and to science and to the fact that things need to be replicated and tested. And it's not to say that people can't make speculative guesses or that they can't take experiments or risks if they don't want to, but as like that anecdote that was shared in the opening remarks about the OB saying it was fine or someone in the ED saying it was fine, those are the sorts of things where we can get ourselves into trouble because the evidence isn't there. Now, the idea behind it comes from the fact that we do have an endogenous cannabinoid system. That's why these products impact us. We have these receptors in our brain, just like we have opioid receptors in our brain. That's why opioids impact us as well. So we've got these receptors, and the thought is, well, let's put in this exogenous agent. Let's take in THC, manipulate those receptors, and get a desired effect and some change in disease state. But the reality of it is very hit and miss. That's really not how this works. And actually, when you look at the studies that have said, well, what are states approving this for if someone's trying to take this to either medicate themselves or be part of a medical marijuana program, what they're basically finding is that there's, like, this one was from a couple years back, hasn't changed. A significant amount of rigorous research is needed to definitively ascertain the potential implications. There's insufficient evidence to support the recommendation. This was from the NAS study of all the different conditions that they've seen essentially states look at, but there's really no evidence either way to support it. These red dots are everyone that's on our list here in Illinois. Worth mentioning that, evidence does move and things do change. This list included epilepsy when this report came out. Now, we do know that CBD seems to be helpful for epilepsy or certain epileptic disorders. But there's all these myths that persist, like glaucoma. This is one of the first conditions that we heard about how it could be useful. But the American Glaucoma Society says don't do it because it basically sends your intraocular pressure on a roller coaster ride, doesn't affect the course of the disease. Doesn't really help. You basically just have to be high all the time. And as a psychologist and one who's worked in VA hospitals for 3 years, I am particularly mortified by PTSD being on the list, as well as, to be honest with you, a lot of other psychiatric conditions, because not only is there no evidence to support that it actually does help, but it's actually contraindicated. We have treatments that work for a lot of psychiatric conditions, for a lot of behavioral health conditions, and numbing out or becoming intoxicated, that avoidance is part of the pathology. And actually, when you look at studies on veterans, what you find is that actually cannabis use makes it worse. And here's another one, that it makes it worse for veterans, not just for PTSD, but also for a lot of other negative health outcomes, psychiatric disorders, self-harm, and suicidality. So these rumors tend to get these really strong legs. And then maybe there are some people where either they like the fact that it numbs them out or it provides some momentary relief, but at the expense of future harm. But that creates anecdotes that tend to get a life of their own. So let's talk for a second, though, about CBD. It's not going to be the main focus of the presentation today, but it's so ubiquitous, I feel like, these days, and everything from like gas stations to food stores, that we should at least talk a little bit about what it is and what we know. It actually doesn't act on cannabinoid receptors, which is a little odd for a product that comes from the cannabis plant. But, such as it is, it works on a lot of different parts of the body, though, 65 different molecular targets, with the most common being something called the transient receptor potential vanilloid. But essentially, it's an anti-inflammatory, as I mentioned before, and the early studies that we have, definitely preclinical, many of them on rodent models, find impact on cocaine self-administration, so fewer seizures, less inflammation. It's an anticonvulsant. Lots of different things that it could be useful for, but not too much has been replicated. A lot of this has been in rodent models, but the breadth has led to this really broad speculation of the usefulness before the evidence exists. This reminds me a lot of what we're seeing with psychedelics right now, in that there are some really interesting studies going on in therapeutic settings in very specific ways. But then we're seeing states like Colorado now just legalize their use in healing centers, which are not doing the protocols, and it in any ways actually undermines the really good work going on at Johns Hopkins and Mount Sinai and others. But that's what's going on with CBD, where the data really isn't there, but it's being put out there as if it is. And the only application right now for CBD that has actually met FDA approvals for human use is epilepsy, as I mentioned before. There's insufficient or mixed evidence for a bunch of other conditions, including pain and anxiety. Sometimes it makes it better, sometimes it makes it worse. There's a couple very recent published in 2022 articles and reviews of cannabinoids as medicinals, CBD specifically, and essentially their conclusions are very similar, that they're not ready for a formal indication as medicine, maybe not even as a dietary supplement. That's a slightly different channel through the FDA, but we're just not there yet. But part of what's really buoyed CBD's rise is that because it doesn't seem to have nearly the same adverse effect profile as, say, THC does, or a propensity to get people into car accidents, so on and so forth, it's very easy to just put it out there. And, worst case scenario, someone's just out some money for the most part. This was a study that was looking at warnings from the FDA from 2015 to 2019 about CBD products. And specifically, what they were looking at was that there were a lot of claims made for cancer, diabetes, inflammation, pain, and arthritis. Because even if we have some of this preclinical data, which means it's not controlled or blinded in the proper way, it just seems like it might be useful, we're not actually allowed to make those claims until we go through a process that is, of course, there to protect the public. So on the safety standpoint of this, again, it has a pretty good safety profile for non-pregnant adults with limited side effects. For Epidiolex, which again did pass through the FDA, it's just a pure plant-based CBD medication. Those side effects are listed as diarrhea, headache, decreased appetite, and sleepiness, somnolence. Also higher rates of pneumonia in children. We know that high doses of CBD can lead to abnormal liver function tests, but we're talking really high doses of CBD to achieve that. So again, for the most part, for a healthy, non-pregnant adult, you don't have to worry about it, but we have virtually zero data on CBD in pregnancy and lactation. So the FDA has strongly advised against the use of CBD for pregnant and breastfeeding women. Is not approved or regulated by the FDA also in any way. And this is the other issue. So CBD as a chemical compound, FDA is strongly advising against the use of it because it just basically hasn't been studied. So you're really rolling the dice there. But in terms of not being regulated by the FDA, the issue here is that they can be impure. And that's something that we're actually finding. Recent studies have found that only 30 to 40% have the advertised amount of CBD, and 20 to 50% actually contain THC, which does have deleterious effects on the fetus. Again, Dr. Shallat will get into that a lot more in a lot more detail than I will. The other thing to know about CBD is that it's actually a molecular precursor to delta-9 THC. So what that means is that when you vape it or smoke it, it goes through thermal degradation, or pyrolysis is a technical name for it. And one of the compounds that's created is delta-9 THC. So even if you've got somebody who is taking a CBD product and thinks to themselves, I'm going to be able to pass a drug test, or I'm not exposing the fetus to THC, one, it very well might be impure. And that's what we're finding with a lot of these studies that have been done that are just pulling products off the shelf and testing them. But if they're vaping it or if they're smoking it, they are also actually consuming, because they're converting it into delta-9 THC and delta-8 THC, which is also a psychoactive product that we have zero information on, honestly. I don't think there's been any studies on delta-8 on pregnancy, although I may be wrong about that. I don't think I've looked at delta-8 specifically. But what we know about delta-9 is pretty extensive. And again, I'll just underscore, I think probably every speaker today will say, it is it hurts the fetus in a number of different ways. It's not healthy for the mother either. Not a good thing to be doing. So I won't go through this terrain myself. I'll just put this slide up here and move on for now, but absolutely it has negative effects on an unborn child. Now, in the opening remarks, the study was alluded to, this one that came out a couple years back that found that 69% of physicians in Colorado back in 2018 actually recommended that pregnant women use marijuana for their morning sickness. And what's striking to me, and I'll have a more recent study in just a second that I'll put up here, is that that when you look at these bud tenders' opinions, they're strikingly similar to 4 years later, even though we have so much more information now. They say things like, different people's opinions, kind of like alcohol. I used to be a bartender, and it's legal to serve someone who is pregnant because it's up to them. So, I'm not here to tell you you should or should not use. Does that make sense? I do know a lot of people that do use cannabis during their pregnancy, though, and for what they have found, there's not been a lot of side effects that they can see. Also, compare this to say a pharmacist. Sounds very different. Or we have a girl that comes in and she's probably 6 months pregnant and she smokes bud, but she does not smoke it as much as she did, but she still does. Her doctor said it was okay. Maybe, I suppose. She said the doctor said that, but I'm not a doctor. I know aspirin is okay for babies. Don't have to tell you guys it's not. And it's pretty much what you were getting is an aspirin that is probably better. So that was Colorado in 2018. It's worth mentioning a more recent study in Canada found that at least Canadian dispensaries, 93% of them did recommend pregnant women to not use it. However, another study out of Canada this year, 2022, found that 20% of dispensaries did recommend marijuana for quote unquote relaxation for breastfeeding women. So 1 in 5 Canadian dispensaries. So they apparently know not to use it when pregnant, but they haven't read the literature on lactation. Now, flash forward again to 2022. Here are some studies about viewpoints of both bud tenders. Those are the people who, I'll take my head out of the way. These are some of the people who, these are the people who serve the marijuana in the dispensaries. And then I've got some studies here on perceptions in the public as well. But this was looking at healthcare professionals and bud tenders' perceptions of perinatal cannabis use. And what they found was that healthcare providers, at least in this study, were pretty clear that it's not a good idea, that it could be harmful to the fetus. But what they found was that conversely, most bud tenders said that cannabis was much safer to use than cigarettes or alcohol during pregnancy. So they would view it and would present it as the safer option. And these are some quotes. So, cannabis seems to be so normal and adaptable with the human body. Isn't as damaging. If a woman wants to do that, there's no harm in it. I mean, smoking tobacco, that's different. So there's a couple of viewpoints, and then I just grabbed a couple of snippets from the study. I'd encourage you to check it out if you're interested in all of them. But they also found that bud tenders had a wide spectrum of beliefs about the impacts of perinatal cannabis use. Some thought really described positive impact related to the mother. Others noticed negative infant and breastfeeding effects. Some believed that there were no impacts. And I won't read this whole slide out to you. You can do that later. But essentially, what we're finding here is that when you get into the store and the people are there to sell it, a lot of what they're pulling from is not the same research that, say, for example, you're going to hear over the 4 or 5 hours that you're here in this symposium. It's very different where they're getting their information from, but it's not peer-reviewed medical literature. And this is echoed then when we get to the public. So this was a really interesting study that was looking at, this was at a Latino majority area, I believe in Colorado, but they were looking at mothers and their opinions about, do they agree or disagree that using marijuana while pregnant does these things? And so these first few were the positive aspects. And so for this one, the concerning side is on the right, where they think that this is a good idea for these to help with those particular problems. And you could see that about 1 in 6, 1 in 7 were saying, yeah, it has no lasting harm for the baby. It's safe because marijuana is plant-based and natural. And this is something where, when you compare this to alcohol, I'd have a feeling that these numbers would be a lot lower. So when you say 1 in 6, 1 in 6 people is a lot. actually to have this misconception, and that's going to trickle down to kids. If you look down at the bottom here, these are all things that we know to be true in terms of the negative impact of THC on the fetus. And again, you can see here the concerning side is the people who disagreed with these statements, either disagree or strongly disagree. And you can see that 1 in 4 did not know that increases or disagrees that it increases the risk of preterm birth, low birth weight, pregnancy complications. 1 in 4 to 1 in 5 people do not agree with that. Here is another study that was looking about this, that was looking at this as well. And they found something very similar, but there's a detail in here that I thought was very important to look at. So if we look just at the results here, participants' perceptions and use of cannabis during pregnancy were shaped by relief from the pregnancy-related symptoms, recommendations from healthcare providers that cannabis is safe, anecdotal stories from friends and family, fear associated with prescription medications, and preference for natural remedies. But this is the sentence that really stuck out to me. The context of distrust of providers permeated these themes. And that issue right there, that the context of distrusting your medical providers is this undercurrent around a lot of this misinformation, is really important, because that's something that we as healthcare providers can work on. And actually, the second half of my presentation to you today, we're going to talk a bit about motivational interviewing and how to have an effective interaction with a patient to potentially elicit some behavioral change and gender trust. Because ultimately, if they don't trust you and they've got these narratives playing in their head, whoever those 1 in 5, 1 in 6 people who's coming into your office who might have these misconceptions and might be using, those are the folks that we need to reach. And we don't get there by like bullying it into them. We have to take a more nuanced approach, and that's where the MI comes in. One more study about perception I want to share with you. This one again came out this year, a qualitative study that was looking at these perceived risks and benefits of cannabis use during pregnancy. The themes, essentially, the big ones were that cannabis is safe because it's natural, that it manages distress without having to go to a doctor, and again, distrust in medical professionals and their recommendations, which is something that I know anecdotally I've heard has been one of the big areas of fallout around the pandemic, where all of a sudden there's a lot of people who are looking at doctors like, are they getting a bonus for using certain medications, or are they pushing their own agenda in some way? And so then when we're offering information, it goes through this lens of, well, I just want to manage this naturally, even when this particular plant-based, quote unquote, remedy is not helpful, which I always think is interesting, because like if I have a window in my office here, and like if I look out my window, literally every natural plant-based thing I can see out there, I should not be eating, and I definitely shouldn't be smoking. Like it's just most of nature is not designed to do that. What we also know, and this is particularly important in our area of the woods here in Illinois, is that actually the closer someone lives to a dispensary when pregnant, the more likely they are to use it. That's what we found, actually. So having retailers within a 15-minute drive was associated with pregnant women to greater odds of use compared to not living within a 15-minute drive. So worth taking a look at where you are, where your patients are, and just factor that into your knowledge. And this is because access always equals increased use when it comes to substances. When it's available, you're more likely to use it. But there's also like a lot of advertising and billboards that comes out of dispensaries that are trying to, because again, it's a business, they're trying to increase their user base. So a lot of the messaging that they put out gets absorbed in the most immediate area, the most immediate community. This study also found something very similar. This just came out a couple months ago. What these graphs show here, this is the one that was a little more striking to me. This is shown based on the number of medical dispensaries in the county where the pregnant woman lives. So 1 to 9 or 10 or more, the amount of pregnancy-related hospitalizations that you can expect. And you can clearly see this increase from, if there's not one anywhere close in the county, to here's 1 to 9, and you can already see that increase. And this is over time from 2011 to 2019. And then this is if there were 10 or more in the county. So when you look at that trend line and the number of hospitalizations related to cannabis, it's obviously very concerning. So more along this line, when it comes to availability of these products influencing use rates, and in particular, use rates amongst pregnant women, as this slide in the last one was pointing out, we got to talk about some of these what are called semi-synthetic THC analogs, because these you could literally buy right now anywhere. You can get them through the mail, you can get them at a gas station. And Delta-8 THC is the most common. It's 50 to 75% as psychoactive as regular, quote unquote, Delta-9 THC that you would get from a marijuana product, but it's derived from CBD and hemp. And so what they do then is, and so the way this works is because under the Farm Bill, you are allowed to sell hemp and hemp-based products. What they do is they harvest the CBD, they get the CBD out of the hemp, and then they put it through a chemical process in a lab, hence the semi-synthetic part, because you're using a natural substance, CBD from a plant, but then you're altering it in a lab to create a psychoactive product that, because it comes from hemp, you can sell anywhere. And it's legal in 39 states, including us. This is what the map currently looks at. Under review is because there was a bill that was submitted to put some sort of control over the sale of the Delta-8 THC that came in last legislative session, but it didn't pass. I couldn't tell you why. It seemed kind of common sense, but right now, kids can buy this, anybody can buy this. Again, it comes from gas stations, but it's completely unregulated. There's no health and safety standards, and it's made using toxic chemicals. This is part of why the FDA put out an article worth reading about the health risks of Delta-8 THC, but a lot of this just is that it's very unstudied. This is a chemical that we don't really know what it does to an adult, much less to a fetus. But unfortunately, this used to be as far as I would be able to go for this part of the presentation, but in the past year, there's been a lot of movement in the industry and things have gone even further. So now we have another semi-synthetic analog that's become more popular called THCO, or THCO acetate. It's about rumored to be 3 times as strong as Delta-9 THC. And I say rumored because we literally do not have any peer-reviewed medical journal articles on this. All we have are anecdotal reports and what cannabis reviewers put on their YouTube sites and, when they talk about it. But this is something that's produced from Delta-8. So again, you can buy it anywhere right now, no controls over it. Like you could buy it from CBD kratom stores if you have those in your area, or again, from a gas station. But it is acetylized. And what that means, so that's the acetate part. When you acetylize a compound, it passes more easily through the blood-brain barrier. So heroin is acetylized morphine, essentially. That's how it has that increased punch and effect. And so this is the same deal. So that's part of why rumored to be 3 times as strong. But doesn't stop there either. Now, there's a bunch of different products. Again, all of this comes from CBD. So you can literally buy this anywhere, which is why when we're talking about availability to pregnant women and what they're coming in contact with and what they're hearing about, you'll also notice, the cartoons that are used on these products and on this cookie, which, you can't do in dispensaries because it appeals to young people, but these are not marijuana products, these are hemp products. But you can actually even now make Delta-9 from hemp. You take CBD and you put it through a chemical process and you literally make the same active ingredient, but you can sell it from a gas station because it came from hemp. And this is a THCO Delta-9 combination pen. And I mean, it's such a huge rabbit hole now, guys, with this and where it goes, where this is an online retailer. And here are all the semi-synthetic THC products that they sell. This particular vape pen is a blend of Delta-8, Delta-10, enriched with THCH and JD. And THCH supposedly binds 25 times as strong as Delta-9 THC. So, I mean, who even knows, right? We have no idea what this actually is going to do to an adult body, to a fetus, really negative stuff. But this is highly, highly available. And a lot of it is couched in this idea of health product, natural product, comes from hemp. That's part of how they're getting around the law. Now, why this is particularly challenging right now in the mental health ecosystem that we're in is that people are really stressed out. Pregnancy alone is extremely stressful for a host of reasons, honestly, that I'm not even going to be able to fully understand because I'm never going to be a pregnant person. But on top of that, we are going through one of the most stressful times in recent memory. The American Psychological Association recently released their Stress in America survey and found that 1 out of 4 adults said that most days they are so stressed they can't function. Like, just straight up. They just feel like most days they're so stressed they can't function. And this is even more for younger people, which do happen to be the age of most women who are going to be pregnant, are going to be younger people. And so people are under a tremendous amount of stress. And the intersection between substance use and stress is that people don't like to be stressed, and substance use can provide momentary relief. If it didn't do that, people wouldn't do that. But that's part of how our brain works, is that even when we have competing ideas or priorities, when we get stressed out, we stop thinking as clearly. And the best way that I can describe this is with this incredibly anatomically correct model of the human brain, which is of a dog driving a Tesla. And why I think this is the best way to describe how our brain functions is you can imagine it having essentially 2 different main components when it comes to reasoning and stress. The first is really highly technologically advanced. That's our prefrontal cortex. It's part of what makes us different from other animals. It lets us do higher order thinking, think abstractly, moralize, think about long-term gain over short-term gain, things like that. Really important stuff. But as advanced as that part of our brain is, it is less powerful than our more primal limbic system, which is where a lot of our urges come from, our emotions come from. It's more of our, if you want to call it, our animal brain. That is the dog that drives our car, because for those who have not practiced a lot of good coping behaviors, when you get stressed out, what that part of our brain wants more than anything else is to not feel discomfort, physical discomfort, emotional discomfort. The second thing it wants, by the way, is to feel pleasure. And so when you talk about getting high, it checks both those boxes. And the dog in our brain's like, oh man, that's a great fix. It fixes this problem right now. This principle, by the way, is what drives a lot of psychological problems, whether it's substance use, cutting behavior, eating disorders, you name it. People are just trying to feel better. They're trying to cope, which again, if you think back to those misconceptions about cannabis products, is where a lot of this was coming from. So now take this principle about how our brain works under stress and the amount of stress we're under. And that's why when you look at what's been happening over COVID, and this was data that was just published very recently, that we've seen an uptick in use during pregnancy just in the past, about 20% increase within the beginning of the pandemic. I don't know what it looked like in 2021. We don't have any data published on that yet, but I'll take my head out again. But you can see here that it was tootling along, as we talked about before, at about 7%. And then as soon as COVID kicked in, you can see, and this is the rate for cannabis use during pregnancy, that it jumped up to over 8%. So we'll see as they release more data where this goes. But we've seen this impact across all different sides of substance use, in terms of alcohol use, in terms of overdoses, in terms of cannabis use generally, as well as during pregnancy, because when people get stressed out, they're looking for fast solutions, and there's not necessarily other good ones available, particularly if there's financial pressure and shortages in therapists. I, for example, actually stopped accepting new patients about 2 weeks ago because I personally am full up. So there's a lot of challenges and people are looking for solutions. So all that being said, the question then becomes, so how can we help with this, and what can we do? And I know that's a big part of why everyone's here today as well, and thinking about, okay, so how can we bridge this gap? How can we make this better for our patients? And so what I'd like to suggest in terms of what you can do to help with this issue in your clinics is to use the SBIRT model, which you may be familiar with, but if you're not, we're going to walk through some different components of it now. SBIRT stands for screening, brief information intervention, and referral to treatment. And it's basically the gold standard approach in brief contact medical environments, whether or not we're talking about the ED or an OB office, or whenever you just have a small amount of time, what you can do. And it's actually got some really good evidence behind it in terms of being impactful. And specifically, so we're going to drill into each part of this, and we're going to talk a bit about motivational interviewing as well and those principles. And we'll do a little bit, a couple exercises with that as well, so that you can see how this works. But the backbone of this SBIRT model is motivational interviewing. And if you haven't heard of motivational interviewing, it is a way of interacting with a patient where you're trying to move them along through the stages of change to find positive goals in ambivalence. And so the idea here is that people aren't always ready to make a change. Like, say, for example, you've got a pregnant person who is who's really stressed out and has been using cannabis products to say maybe for them it decreases their anxiety. Not always the case, by the way. For some people it actually makes it worse, or they've just gotten addicted and they have to use it to feel normal. But say that they've been using it for that. Well, if you are kind of putting on them, you just got to stop, they might be like, well, how am I supposed to deal with my anxiety? What am I supposed to do now? And so ideally we want to move them further along these stages of change. Very briefly, the way we conceptualize this is that if someone is pre-contemplative, that means before thinking, pre-contemplating. They haven't even really thought about the idea of change. Contemplation is they've thought about it and they can see the reasons why it might be useful to make a change, but they're not actually ready to do it yet. But they're not, you can kind of think of pre-contemplation as like being in denial. Preparation is when they've decided they're going to make a change, but haven't taken that step to do it yet. Action is when you start the process of change, and then maintenance is after you've made a change and you're looking to maintain it. And so the idea of motivational interviewing, generally speaking, is to get folks out of this area, the pre-contemplation, contemplation, down into preparation and action so that they actually do something. And motivational interviewing is useful in a number of different areas: medication compliance, but as well as lifestyle change, decreasing substance use, etc. The purpose of this type of interaction is to develop discrepancy between the current state and someone's goals. And this idea of developing discrepancy is very different than telling someone, you need to stop smoking marijuana products now, or you can't keep taking your edibles. That is very directive and it's pushing. And a phrase I'm going to use a lot in this last portion of the presentation today is that if you push, someone can push back. If you don't push, they can't push back. And so part of the motivational interviewing approach is to present them with ideas to help them sift through their own thoughts and develop intrinsic motivation for change rather than you pushing change along. So a way to conceptualize this is dancing with someone and not wrestling. So a conversation should never feel like you're trying to just like wrestle them into submission and be like, I'm gonna make an argument so that you stop doing something that's harmful to you. That's not what we're trying to do here. You want to think about it more like a back and forth. If this isn't just an easy pitch of you being like, hey, so you marked down on the sheet that you use cannabis products recreationally. How do you feel about stopping? Sure, I can stop. Great. Like, okay, fine. Like that's fantastic. But if it's something where there's not necessarily a lot of buy-in, you don't want to feel like you're wrestling or pushing them. There are 3 types of conversation styles that we talk about in MI. The third one, guiding, being the one you want to shoot for. Directing is just very directive. I'll tell you how to solve this problem. You need to stop using these products to protect your baby. Following is the opposite of that, where I'm just going to sit back and help you sort through your thoughts, trust your own judgment. I'm not really going to influence your opinion in any way. But guiding splits the difference, where basically your orientation as a provider is, I'm going to help you solve this problem yourself. And to do that, you have to resist what's called the writing reflex, where you have this reflex of when someone says something that you know is false, like it's natural, so it's fine, or like it's safer than using a pharmaceutical that's maybe been tested, that has been tested, but they're saying that it's very easy to just jump on them and be like, oh no, like that's wrong, or that's misinformation, or just write their opinion to what you think is right. But you got to try to resist that, because that's what pushing's all about. If you push, they can push back. If you don't push, then not only might they not push back, but if they take ownership of the idea, they're much more likely to sustain it when they're not sitting right in front of you, right? Because it's one thing to get someone to say something when they're in your office for 15 minutes, and it's another if they have to then go back home and do it on their own accord. So a good model to use for how to communicate through a motivational interviewing consistent approach is communicating with love, which stands for listening, offering, validating, and empathizing. So as you're communicating with somebody about this issue, think of these principles as you do it. Listening is short for active listening. So you need to actually try to understand where the other person is coming from. People love to be understood. It opens them up. It gets them to share more and actually then be more receptive to you as well. And it shows them that you care. And so the way that you can show active listening, there's a number of ways. I'm going to highlight two here. One is through an open-ended question, and another is through reflecting. So open-ended questions are questions that tend to start with, tell me more about, or what do you appreciate about this, or what do you have to gain from something else? Not questions that could just be answered with a very quick yes, no, something very terse or cursory like that. Open-ended questions help people share. And I know this is sometimes at odds with really fast times where you've just got to go, get through an appointment really quickly, but it's worth it, because if you can take that extra time, build some rapport, understand someone, they're much more likely again to carry that behavior on when they're not sitting right in front of you. Reflections are also bread and butter way of letting somebody know that you're listening. All you do is listen to what they tell you and then repeat it back to them using different words, or even including some emotion that they didn't explicitly say. When you do that, it shows them that you were listening to them, which again is the heart of creating a connection to someone in communication, is you've got to show them that you're listening. So when you repeat it back, it shows them that you were listening. And when you use different words, they know you're not just parroting it back, that you've actually got them. This, by the way, like hashtag therapist tricks, this whole slide, this is what we do in the therapy room. The O stands for offering. So specifically, how do you offer that information or feedback, which is something that you're probably going to have to do in the case of if you have, say, a pregnant person who is using THC products or cannabis products and isn't entirely sold on stopping. At some point, you'll have to give them some health information. How you do it matters. What you want to do is use what's called a feedback sandwich. And that is where you sandwich the actual advice between two slices of autonomy. So the first slice of autonomy is you ask permission to share the information. So you would say something along the lines of, do you mind if I share some information about what we know about the influence of cannabis products on the fetus? If you ask about that, what that does is it's changed it from you putting it on them to them literally asking for the information. And again, what we know from research is that this actually opens their level of receptiveness to that information. So first you ask if you can share the information. They will almost always say yes. Then you provide the information that you need to provide. And then afterwards you ask them for their reactions. And you can even ask if they agree or disagree. And what that does, again, is it gives them the ability to decide for themselves if they want to take it in the moment. And so when they reflect back on the interaction, or they think, what's my idea versus what's the provider's idea, they're going to remember that they gave permission for the information. They were given the information in a non-directive way, and then they were asked how they felt about it. And so if they agree, they've now taken ownership over that in a very different way than if they were just given a pamphlet or told you need to do this if you care about your child. The V stands for validating. And when you validate somebody, it reinforces their self-efficacy and self-trust. What this looks like is that if you have someone in your office who's using these products and who's says mixed feelings about it, or potentially doesn't want to stop, taking a second and validating that, yeah, like life is really stressful right now, or you've got a lot of pain and you're trying to find a way to get through your day. And we all want that. We all want relief. We are all trying to find a solution. Taking a minute to do that helps them see that you care about them, that you see them, and that you understand them, and is very closely related to empathizing. To borrow a phrase here from Brené Brown, you want to get in a hole with somebody. You want to really try to feel what they're feeling. And instead of just kind of like writing in to save them with what you know as a healthcare provider, or stop them from hurting their unborn child or whatever it is, you want to make very sure that that's not the vibe that you're giving off, because that can be very off-putting, perhaps for obvious reasons. Again, it's very easy when we're behind our own lens to make some of these mistakes and create that dynamic, which creates pushback, which means people are less likely to move forward. And the last part of this to be very aware of is that it's really okay to go slow and schedule a follow-up. Yes, ideally, particularly when we're talking about gestation and development, ideally behavior changes as quickly as possible. And, if you're able to just, convince someone or to use these techniques and be able to make a positive change like in the moment, that would be great for everybody. But if you're pushing and you're feeling like you're starting to wrestle with them again, like it doesn't feel like you're going back and forth, there's receptive, it's okay to see like, well, what steps are they open to taking today? And maybe we bring them back to the office again sooner and we talk about it some more. So I want to give you a couple examples of how this might look in terms of the sorts of responses that you could use. Not all of these are going to be pregnancy related, but just to give you an example of again, the vibe of this. So say you've got someone who says, I keep having fights with my husband almost every day. He's really stressing me out, and he says things that make me feel awful about myself. So like something that would be very directive, maybe even we'll say quote unquote friend would say would be like, clearly your relationship is dysfunctional, fix it or leave it, like make a change, this is a problem. But if you're using the spirit of MI, you would reflect back that your relationship is hurting you and you're not sure what to do. Have you resolved issues like this with him before? Refer back to times like how would you shift this? So here, perhaps a little more topical, I know I shouldn't smoke every day, but I can't take the time to get to treatment. I'll never be able to keep up at work. So you could say like the consequences of your smoking on your child are far more important than work, and you're able to take FMLA, pick up the phone and dial, like get to rehab, take care of the THC issue. Again, it might be like let's fix this right now, but what has a much better chance of working is you can see that the smoking could potentially hurt the baby, but you're really worried about work. So what do you think a reasonable next step might be? So asking them how they feel, reflecting back that they're conflicted. So sitting with that ambivalence, not trying to write it, right? This is avoiding that writing reflex, giving them some room to explore and to talk, and then to magnify the parts where they're interested in change. And this topic, I know I'm going just very over the surface of motivational interviewing. We could literally do a whole day seminar on just that alone in terms of how to do it effectively. But the general idea of this, again, is what you're trying to do is get with them in that place of ambivalence and offer advice in a way that doesn't get pushback, and try to help them see the positives to change and move in that direction. So that's the groundwork in terms of the general orientation that you want to take when having these interactions. But to even know if you need to have them, we got to talk about screening. That's the S in SBIRT. Because if you don't know if something is going on, you can't take a step to change it. And so there's a lot of different ways to screen for substance use in general, and specifically in pregnancy. However, there was a study that came out about 3 years ago looking specifically for pregnant women about what are the best screens and why. And so what we want to look at here, this is looking at a number of different results, but this is as it coordinates with urine test results for what detects substance use in pregnant women most effectively. What they actually found was that the SERP-P and the 4Ps plus have slightly higher sensitivity than the NIDA quick screen, which is another very common one. And although specificity is a little bit higher in NIDA quick screen. So sensitivity means how likely you are to detect a problem. And in a screener, that's what we value the most. So this means what are the chances that you're going to get a false negative? You miss a problem entirely. Specificity is the chances that you're going to get a false positive. And again, in this case, it's much better that that you get some false positives for a screening test like this, because asking them about what their use habits are and them saying, oh, actually, like everything's fine, is much better than actually them actively using cannabis products and you not knowing about it because your screener wasn't sensitive enough. So the SERP-P is actually just 3 quick questions. Have you ever used marijuana? How many alcohol drinks have you had in a month before you got pregnant? And do you feel the need to cut down on your alcohol and drug use? If you Google it, you can find, I couldn't actually find a good image, which is why I don't have it in the slides, but it's completely open source. You can plug it into your EMR and you don't have to worry about any concerns in that way. The 4Ps plus is copyrighted, but they actually do provide the screenshot on their website. So I put it here. So you do have to pay a little bit to use this one, but it's a good and slightly more detailed tool. The 4Ps are parents, partner, past, and pregnancy. And so it's still a very quick screen that if they say yes to any of these things, you go down to a second set of questions that you ask, and then there's an interpretation guide. It takes a little bit more training to do this, a little bit more time to do it, but if you feel like this would be clinically relevant, definitely can be worth the time. The NIDA quick screen, which again has lower sensitivities, so not quite as recommended, but 85% still has anything to screen at. It's also very quick. It's just in the past year, how often have you used the following? And asks about alcohol, tobacco, prescription drugs for non-medical reasons, and illegal drugs. And obviously it's positive they say anything other than never, and you can follow up on it then as well. But again, this one has slightly lower sensitivity. So the SERP-P, that 3-question one, or the 4Ps plus, those would be the recommended of the bunch, but this one is not bad. So screening. Now let's move on to the brief intervention. So this is going to be short in duration, kind of has to be, but we're not looking for a really long conversation. You're focusing on that motivation enhancement. So again, moving someone through these stages of change, having that motivational interviewing, consistent dialogue to help explore their ambivalence. Things you can do to help move them along are ask questions to highlight the downsides of use and the benefits of change. So some ways you could potentially do this are asking, are there any aspects of using marijuana while pregnant that concern you? Open-ended question, right? I mean, well, it's possible. Actually, I take it back. Maybe I should rephrase that. If they say no, then I guess that you kind of have to pivot a little bit. But if they do have some aspects, then you could ask them, tell me more about what those are. Again, I think it was about 1 in 6 people thought that there were 0 problems with it. I think a lot of folks, instead of just being convinced that there's none, would at least have some questions. Or if you find a different method for managing your anxiety, do you think this would have a positive impact on you and your baby? How so? This question is not saying it would have a positive impact. It's asking them, do you think it would be positive? And why do you think that would be the case? And if they say, well, I think it would be good, but I don't exactly know why, then you bring in the information that you're going to hear in Dr. Shallat's presentation about why specifically it will be better for the fetus in particular. And you can offer that up after, of course, asking permission if you can give that information. Another thing that you can use, and you'll actually see this in the video I'm going to show you in just a second, a brief demonstration, is called a readiness ruler. And a readiness ruler is a really nifty tool to use to get someone talking about why they want to change. We actually have a name for that, change talk. And we'll talk more about that on the next slide. You want to get people talking about why they want to change. This is a great way to do it. All you do is you ask someone on a scale of 0 to 10 or a scale of 1 to 10, how motivated are you to stop using cannabis or to Or how you can also do this with importance. You can have an importance ruler. How important do you feel it is? So like say someone throws out like a middle number, like they're not quite sure. So say they say it's like a 6. They're like a 6 out of 10 in terms of their readiness for change. Well, then you follow up with a question. Okay, so why did you pick a 6 and not a 3? And when you do that immediately, they're talking about why they think they're ready and not less ready. Really nifty intervention strategy to get people talking. Another thing you can do if someone says that their readiness is pretty low, like a 2 or 3, is you could say, okay, so sounds like you're not too ready for change right now. What do you think it might take to make you feel a little more ready, to get you up to like a 4 or a 5? Then again, they're going to give you information about what they think would make them more ready to change, or the same thing in terms of importance. Like, what do you think might change your mind on this, bring you from like a 2 to a 5? Is there anything that you could hear that might make you think differently about it? Then again, they're sharing their own feelings about what would bring them closer towards readiness to change or make them feel like change is more important. The last thing in this brief intervention that you're looking to do is obtain a commitment for an action if it's appropriate to do it in the moment. So if you can get someone to say, I'll do this, or this is going to be my quit date, or I'll give all my edibles to so-and-so. If someone actually says they're going to do something to you, that's more strongly associated with change. And then again, schedule a follow-up. Don't put pressure on yourself or the patient to get it all done right now. That again, that pressure creates pushback. That can create some counterforce to change. And with this sort of approach, you're really looking to just go with what the patient gives you, help find their motivation. And if they're willing to take certain steps, call that a win and try to bring them back sooner if they're open to it. So some other ways to think about how do you get people talking about this when you're having that interaction, you want them to talk about why it's better to change. And there's categories for change talk. And if there's one thing to remember from this half of the presentation, it's going to be, in my opinion, what's on this slide, because this is something that I think about very commonly when I'm doing motivational interventions in my own practice, is that you're going to try to get them to use what's called preparatory change talk, or the acronym for this is DARN. And this stands for desire to change. So statements about why they want to change or hope they can change. Their ability to change, so why they are optimistic that they can, or why they have the personal strengths or tools to change. Reasons why they need to change, and this one can be a really good one to default to in the case of pregnancy and not wanting to harm the fetus. And then also, or rather reason, I got those reversed, I apologize. That's need. Need is when you need to do it. Reason is how things will be better once you make the change. What are the consequences, like to have a healthier child, or to take care of myself, to not wonder and look back, like if I'd done something different to avoid guilt, what it would have been. So that's where a lot of, if you're going to do this sort of dialogue with a patient, if you have that hat on of how do I get them talking about their desire, their ability, their reasons, how it'll be better, and their needs, how do I get them saying those sorts of things rather than me saying those sorts of things? The second part of change talk is called mobilizing change talk, when they're ready to make a change. That involves commitment, so statements of commitment when they say, I'm going to do this, I will do this, I'll plan to do this. Activation, which is that I'm willing to try, which is actually less advanced than commitment. It just doesn't spell cat. So I think that the people who made up motivational interviewing put them in the opposite order. And then T is that they're actually taking steps, when they're talking about what they've actually done to make that change. That's great. That shows intention, that shows desire, really helpful. We know from research that what's most predictive of long-term change is how often they make these statements in interaction with you, how strong of change talk they use, and if they're making statements of commitment. So if you have the time to have this interaction, think to yourself, what questions can I ask to move a question in this darn cat direction, specifically the desire, ability, reasons, and need, and then if they're willing to make a commitment to do something. Really helpful. So here's some ways that, again, I just want to give you guys some items to draw from, to look back on later. If you look at these slides, you're thinking like, how can I talk to people about this? So you can literally just ask a question to evoke change talk. So what are some reasons why you want this change? How would things be better for you or for your baby if you changed? How do you think you're able to accomplish it? That speaks directly to ability, right? So reasons is that first one. Second one might be desire, might be reasons. That one is, do you think you're able to? That's right in ability. How would you like things in your life to be different? Where would you like to go with this? And then what's your next step? What do you think comes next? Or what's one thing you could do this week that would help you decide if this is something that you can do? So really trying to just bite off whatever is there to chew on and to move someone forward even a step. And again, remember, if offering information is appropriate or necessary, make sure to use the sandwich model, where you first ask permission, then you give the advice, and then afterwards you ask how someone feels about it. So what I'd like to do now is I'm going to show you that brief video. We're doing pretty well on time here. So I'm going to show you a quick video, 5 minutes long, of a provider talking to a patient about quitting smoking cigarettes, so nicotine. If you've got your tab handy or your phone handy, what I'm going to do is I'm going to pull up a question on Menti, where you can write down some of what you're seeing, the change talk, the darn cat, what you're seeing come out of the patient based on the provider's questioning. So just as you hear it, go ahead and put it in. I think I've made it so that you can put in as many as you want. So we'll just compile that throughout the video. Afterwards, don't put your phone too far away. We're also going to talk about the vibe that you got out of the physician. And then I'm happy also, I think we've got a good mic in the room. So if folks in the room, if you'd like to actually speak your answer, that's fine as well. But this is the best example I could find in video form of someone demonstrating MI consistent principles. So I'm going to go ahead and activate that right now on Menti. So pull that up. You should see your phones change in just a second. And we're going to take about 5 minutes and watch this video. So here we go.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently. And I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job. And so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes. Yeah. Some people have a glass of wine. I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why do you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him. And on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right. Yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what? I'm not going to risk that.
Mm-hmm.
So
the risks were so scary then that you were able to stop, but they don't feel as scary to you now.
No, I mean, we're two separate people. And like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
yes. Yeah.
Okay, but it sounds to me too, like part of you really does want to quit.
Yeah, I know that I need to. I, keep every new year, I say, okay, this year I'm gonna quit smoking, but then something happens and it just doesn't.
It's
And
on your
quitting
to-do
doesn't
list,
happen.
it's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5, kind of in the unsure area. Like I
Mhm.
know I've done it before, so I know I can do it. But at the same time, it just seems really hard and it's not
Sure.
the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand
Mhm.
what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure.
So-
Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you. And sometimes just having that support can be a big part of it, especially for people like you, where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure, it feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great,
Thank you.
sure.
All right. So interesting, right? It's if you haven't seen anything like that before, it can come across really differently in a situation where it seems like there's like a right answer. And let's pull up. Thank you for everybody who responded on Menti. And if you haven't, please feel free to pop on there and join us now. But here are some of what you guys were saying, that getting mom to think about baby, validating, looking at what was successful in the past, using a lot of reflecting. And we heard this, right? We heard her ask questions that elicited a lot of that ambivalence, a lot of change talk. Let the mom make her own choices. You heard at the end, she could have maybe done a little bit better of a job asking permission. She kind of like asked, but then just bowled forward without asking for it. But you also saw her like not try to push forward at all about, not feeling about when the medication became an issue. I think actually we're not gonna do the verbal call and response. We've only got about 10 minutes left. I got a couple more slides and I want to make sure we have time for the Q&A. But hopefully you saw how much ground you could actually cover there in 5 minutes. If you're interested and you want to poke around on YouTube, you can actually find the more confrontative version of this interaction, and you can see how less effective it is. And even though obviously these are actors, and so it's a little bit of a caricature, it's very easy to see how, okay, like if I take this approach, I might end up being more successful. And 5 minutes is usually doable, or should be doable, particularly about an issue like this, which is definitely a health risk in terms of the fetus's well-being. So let's go ahead and we'll finish the slide deck, and then I definitely want to make sure I have time to take any questions that are still there. So referral to treatment is the last part of SBIRT. You got the screening, the brief intervention, and referral to treatment if necessary. If they think that they want to change, they may struggle, treatment can be really helpful. I know I'm biased as a treatment provider, but definitely recommended. it should account both for the underlying cause of use as well as the use itself. So like if you've got somebody who is very depressed or very anxious, and that's why they're using, or whatever the reason for use, because ultimately, as I mentioned before, with that cute dog driving the car, substance use is a coping mechanism, particularly if someone is using it in a situation where there can be harmful consequences to themselves or somebody else. It's because they're getting something from it that just feels psychologically essential. And so addressing that psychological need is also really important. Just very briefly, things to be aware of for treatment options in wherever, when you look around your area, you want to know what's there. So in terms of the outpatient side of things, sometimes an individual therapist who's got an addiction certification. I have one from a national body called MAC, a Master's in Addiction Counseling, but here in Illinois, we also have an agency, IODAPCA, that provides a certification called the CADC, which is also very good. But an individual therapist or an intensive outpatient program or partial hospitalization program, it's useful to know, one, what to look for, but then also within where you are, who the providers are around who are of good repute. And then on the inpatient side of things, if someone needs to go to detox, knowing where to send them for that, or a residential facility. I don't know of too many that have specific programs for pregnant women. I think they actually have one up in Chicago at Haymarket, actually, but I don't know about anywhere else in the state offhand. That definitely a question for folks who, I'm up here in Chicago, so I know that area a little bit better. And then peer support, definitely worth putting out there that things like 12-step fellowships or smart recovery can be very helpful. They do provide, though, different things than professional treatment. It's all valuable, and it's actually been shown to positively move towards change. But at the same time, if you've got someone, say, who's dealing with a lot of anxiety that needs to be taken care of, they may benefit from actually working with a mental health or behavioral health treatment professional. If you're looking for referral sources, keep an eye out for making sure that they're accredited. So either by the Joint Commission or CARF or COA, those are the three badges to look for, to ask about, to make sure that where you're sending someone is a good place to go. So if you're looking for additional resources on motivational interviewing to study more, because I know this was a whirlwind, this is the main book, Motivational Interviewing in Healthcare. Actually, they just came out with this new edition, like literally in the past month or two. This book actually is my favorite. I recommend this book to people who are not in healthcare but would like to learn this. So teachers or even therapists. I still think the book written for physicians and nurses and other providers is better. So it's a really good book, very easy read, super actionable, worth getting. If you're looking for a book just to practice skills, this is the one that I'd recommend. And when I do MI training webinars for, like multi-hour trainings, this is what I go to, Building Motivational Interviewing Skills, 2nd edition. Lots of really good skill building in there. So, all right, let's go ahead and sum up and then do a question roundup with the time that we have left. So what we covered today was that, first off, cannabis, not the same thing as cannabinoids. Cannabis, marijuana, hemp, THC, CBD, hopefully all of those terms, you guys know exactly what they mean and can use them and can understand also how they relate to the actual science-based therapeutic applications for these that are limited but present. THC works through cannabinoid receptors, CBD through different ones. They also do act a little bit on serotonin receptors, but still not those in the brain. Is not a psychoactive chemical. The delivery system is not consistent, though, with current models for medication, which is where speculative treatment comes from, poor product choices, self-medication, unregulated products. If someone is looking at this from a medical or therapeutic, if they've got that hat on. Hemp products and CBD products are being altered for euphoric properties as well. So this is something that is way more available, particularly in our state, than virtually anywhere else in the country. And so when we're talking about these products, someone might, it's worth asking both about CBD. When you ask someone about cannabis or you talk to them about marijuana, they might not even think about CBD as being one of those things, even though only 30% of them are accurate, and up to 50% in some studies have found THC contamination. And if you vape them, you turn into THC. So we got to make sure that we cover all the different sides of this, as well as some of these semi-synthetic products that are available just everywhere. THC use does have significant risks for pregnancy. More on that from Dr. Shallat very soon. In clinical settings, you want to intervene using an SBIRT approach, which is rooted in motivational interviewing, which uses this guiding communication style. Pushing allows for pushback. You want to meet someone where they are. You want to validate them. Think about that LOVE acronym as well. Can you listen? Can you offer advice in a way that maintains their autonomy? Can you validate them? Can you empathize? And slowly work their way towards change by helping kind of like increase the size of the fire that they may already have because they care about the health of their child. And again, we know that this is a very risky thing to do if that's something that you care about. So thank you guys for the opportunity to speak to you today, for paying attention. Hopefully the virtual nature of this didn't detract from the information, which I think is just so important, and was really glad to be able to talk to you about today. Again, if you have questions that we're not able to answer in these next, oh gosh, like 2 minutes or so, unless I'm going to edge into your break, just drop me a line. I actually published a blog article on THC and pregnancy. So if you poke over to my blog, you can find, I think I put that out a couple months back. There's a good roundup of studies with links to the PubMed articles in there as well. So thank you again. And if there's any questions in the room, happy to take them. I'm also just on my screen. I'm going to check out, as I'm going to look around a little bit now, but I'm going to see if there's anything on Menti that we should pay attention to. So happy to take any questions. All right, I am not seeing any questions on Menti, so we're good there. Any in the room? So if you are still muted at the moment. So if you can unmute, I can take questions from the room.
In any of the studies you looked at, was there any correlation between smoking marijuana and cigarette use, or like any sort of other drug use? Or was it specifically just looking at pregnant moms that smoked marijuana? Just out of curiosity.
Good question. I did not look for the correlation. What I can tell you is that we do see that correlation amongst youth. That's another subgroup that I think about and talk about a lot, is that absolutely we find that people who are vaping nicotine are more likely to be using THC products, who are more likely to be using other substances as well. So I don't know specifically for pregnant women, but I'd be happy to, if you send me an email with that question again, I'd be happy to poke around and see what I can find in the literature. Or if open invitation, if anyone doesn't have access to a journal article, just drop me a line. I'm on faculty at U of I, and I'd be happy to pull it for you.
All right, thank you.
Mm-hmm.
We talk about the effects of secondhand smoke with tobacco. What are the effects of secondhand smoke with marijuana in terms of being in a room with someone who may be smoking? And from there, is it possible to have a positive maternal or neonatal toxicology if a mother did not smoke or use herself but was around others who did?
But that is highly unlikely, actually. So there are definitely carcinogens that come out whenever anything is smoked, and secondhand smoke from marijuana does contain those things in it. What we know though is that you would have to, they did almost like one of these like comical type studies back a couple of decades back, where they had like a bunch of people smoke marijuana in a car and then have other people sit in there and see whether or not they ended up absorbing it in. And it was not actually at a clinical cutoff. So chances are, if something's positive, it's more likely contamination from something that they did have. They might not be reporting truthfully. I would say probably not the best plan to be around a bunch of smoke anyway. I'm not in the OB space myself. I'm a psychologist. But I would not expect the test to be positive if they were around someone smoking in any sort of ventilated area. It would have to be a lot of very concentrated smoke for that to happen.
Thank you.
Mm-hmm. Any other questions? Maybe I answered them all in the talk. That's good. That's good.
There's a,
There's a question on the chat. You can't see it.
All right, question on the chat. Where can we find some research articles you used in your presentation today? What do you think healthcare providers can do to evoke a better trust level in society? Well, so the research articles, you can always just type their name into PubMed or Google Scholar, it'll pop up. And if you have access, you can download them or let me know. I cited dozens of them, honestly, today in the presentation. In terms of what we can do to evoke a better trust level, that is really tough and a really long conversation about where people are getting their information from and how trust in institutions has been eroded. What I would say is that I find that the best way to make someone listen to you is to make a connection and to be genuine and to be one human being talking to another. And so on like the meta level of like, how does healthcare regain the trust of the people who have lost faith in healthcare? That is a very broad question. But when you're talking about how do you as a nurse or physician or PA or a healthcare provider in some way, how do you bridge that gap to the person sitting in front of you? I think that just has a lot to do with the principles we talked about today of showing respect, being transparent, asking people about their sensitivities, validating them, being an open book. And to a certain extent, there's only so much we can do given the position that we're in. But that's what I choose to do. I mean, I try to just be very open, genuine, not pontificate too much, or when I have opinions, be pretty transparent that I have opinions. But we just got to be human beings and upfront. Kind of a cop-out answer, I know, but that's the best I got. Anything, I can keep staring awkwardly at the camera too. That's I can do some stand up. I think I'm at the end of my time though. We don't have to play me off. It's all good though.
Okay. Well, if we don't have any other questions, thank you, Dr. Weiner. This was really helpful. We all just want to do right by the clients that we're seeing. It was good to see your research and honestly validating what we're seeing in the trenches. And this really gave us some practical things that we can put into place. So thank you for being with us today. And yes, this virtual component was excellent. So thank you for that. Everybody, we'll take a 10-minute break. So go to the bathroom, get some water if you want. Oh, 20? Sorry, correction, 20 minutes.
Break it till 2:35.
2:35. Thank you.
All right, I'm going to take off, everybody. Be well. Take care.
We have. Okay, I think we're gonna go ahead and get started. Thank you. So it'll be a little different this afternoon. We're gonna have Dr. Shallat speak. Just a reminder, we do have virtual participants as well, so welcome back, everyone. Again, my name is Julie Herzog. I'm going to go ahead and introduce our next speaker, who I have the pleasure of working with. Dr. Shelly Shallat is a Tazewell County native, now working for OSF St. Francis Medical Center. She attended the University of Illinois Chicago Medical School, followed by a pediatric residency at Cincinnati Children's Hospital Medical Center. After starting her career in Naperville, she relocated to the Peoria area and never plans to leave. We hope not. We're going to keep her. She has 23 years of experience as an outpatient pediatrician and is now the medical director of St. Francis Medical Center's newborn nursery and clinical assistant professor at the University of Illinois College of Medicine, Peoria. She is a founding member of the Central Illinois Breastfeeding Professional Network, which brings together community partners and healthcare providers to support community lactation efforts, as well as a medical director for the Peoria County Family Connects nurse home visiting program. On the state level, she is an active member of the Illinois chapter of American Academy of Pediatrics and is the Neonatal Advisory Board for Illinois Perinatal Quality Collaborative. My goodness. So I have my pleasure to introduce Dr. Shallat.
I love Central Illinois. I've been different places, and so like I said, I was so excited to come back and work here, back having grown up in Tazewell County. So thank you for inviting me to speak on this topic of marijuana and newborns, and I really want to thank Dr. Weiner. I thought that was just a very informative presentation. I learned a lot, and I really loved the motivational interviewing, really all of it. So I'm glad thanks to him for that lovely presentation. Okay. And, okay, I don't know where that's on there. There we go. Okay. So objectives for today. Well, I guess first of all, I was curious as I was preparing this. I'm obviously on the hospital medical side and as an outpatient. Are most of the people here in the room are in the public health space? I know we have nurses. Any people here from clinics or the hospital, or mostly public health space?
The three of us are doulas.
Oh, wonderful, wonderful. So you have, yeah, excellent.
We're midwives.
Oh, good. Okay, wonderful. Well, maybe I will see you around over in the hospital. Yeah. Oh, yeah. And my daughter's getting her master's in public health right now. I'm so proud of her too. So, for working in this space that you all do. But objectives for today is really we're going to describe the health effects of maternal marijuana intake during pregnancy on newborns, explain indications for testing and reporting newborns for substance exposure. Really start to identify local partners and resources to support our families in relation to marijuana use, and you are all the experts in that. I'm learning from you. And then I did add an additional objective, which is really to discuss the positive impact of the public health and medical community partnership, how powerful that could be. Right, Julie? Yes. And so why am I specifically talking about this? That's not what I want. Sorry, I should have tried out my clicker before.
Are you using the button on the side or on the front?
I was using the button on the front.
He recommended the one on the side when he gave it to me.
How do I get it back to full screen? Okay, all right, so this is where I am. We'll hope this rolls. So why am I here talking about this? I think I'm a newborn hospitalist and a pediatrician. So, and we see a lot of babies and moms, obviously at the hospital. I'm an educator. I work with residents and medical students, and they are constantly challenging me with questions. And then I'm a person who's really lucky enough to know a lot of new parents. I think that the community partner piece has been something I've been learning more about in recent years, and really working with them, collaborating, and how that can help our families. I'm learning about that. And then from everything that's been happening, I decided I really needed to know more. So when the health department asked me, I said yes, not because I know everything, because I recognized it was a perfect opportunity for me to learn and to bring knowledge back to my institution. And additionally, there's really just strong evidence, especially after preparing this talk, in the literature and about the negative health consequences for prenatal cannabis exposure in children. So really thinking how we can work together on that messaging. Okay, side button.
On the side of the clicker, you can either push up or down.
Mm-hmm.
I don't know if that's how it worked when he did it. Slides for her. Do you want me to advance it?
Sure. Okay, so, thank you. So we just learned about this, but for my own learning, just really going through a quick review to level set about terminology. These are complements of the Merriam-Webster dictionary, but cannabis, as Dr. Weiner shared, is really the plant, the entire plant, a tall Asian herb. And then marijuana is the psychoactive portions of the plant that people use for intoxication. He shared this too, that a cannabinoid is the biologically active parts of the cannabis plant, of which there are many. I think he said over 50. And then the THC is a cannabinoid, and it's the psychoactive cannabinoid, one of the psychoactive cannabinoids. He was sharing some others that were synthetic. And then while the CBD, which is cannabidiol, is a cannabinoid, but it's non-intoxicating. So both of these are biologically active. One is intoxicating, the other not. Next slide. The endocannabinoid system is an intricate system of cells, receptors, and pathways of cell signaling. And the biologically active THC acts on the CB1 and CB2 receptors, as he shared. And there are naturally occurring cannabinoids. 2-arachidonyl and anandamide are two of those. And it's really important to note that these receptors and naturally occurring substances, they play a big role in brain development. The natural endocannabinoids regulate neuron development and maturation prenatally. And it starts early in the second trimester. Next slide. So as I said before, I spend a ton of time in the nursery with all the cute babies. I have the best job and the learners. I love my job. So kind of going to weave a case in here for all of us. And we can refer back to it as we go through the presentation. So we have baby A, and she is a lovely 39-week and 2-day-old female born by vaginal delivery to a 20-year-old mom. Gravida 1, para 1, meaning first pregnancy, first delivery, as our doulas know very well. And the rest of the history is that mom did suffer with some significant nausea during her pregnancy. She started her prenatal care on the later side, around 20 weeks, and her ultrasounds revealed a smaller size baby. Mom also says she has asthma and anxiety. Her social history is she's in junior college right here at ICC. She lives with her mom. Her partner is present and active, and she does use marijuana 4 times a week. We know this from the history, just from conversation, medical history, and both of our hospitals in town use a standardized validated screening tool, which Dr. Weiner also mentioned, and ours is called the 5P. I think it's modified of the 4P that he was sharing. Next slide. So moving on to the exam. This baby is gorgeous, beautiful, awesome, lovely family, engaged parents. The baby looks wonderful. There's really nothing concerning on exam, maybe a little jitteriness, but the baby is noted to be what we call small for gestational age. So when we graph that baby on the growth chart, and we graph it by how many gestational age of the baby is at birth, this baby is in the lowest 10th percentile for how big they are. And that is compared to other babies with the exact same gestational age. Next slide. We did check some labs on baby A, some really kind of standard things we do for babies, which is a blood type. Because baby A was a little small, we are monitoring her glucoses and they've been going fine. All babies do get a newborn metabolic screen, which is sent off to the state, and it checks for some rare diseases like sickle cell, CF, hypothyroidism. Because of her history of late inadequate prenatal care and the fact that she shared she had used marijuana during her pregnancy, she met our hospital's what's called our risk-based criteria to send to cord toxicology for this baby. And we should have shared with her that that was being sent. Next slide. So what is this inadequate prenatal care? Prenatal care begun after the 4th month of pregnancy or less than 50% of the recommended visits received is how that is defined. Unfortunately, and as our doulas and any other medical or even health, anyone here probably knows, we have really a paucity of access for prenatal care in our community, especially for people with Medicaid. Sometimes it can even take 6 to 8 weeks to get their first prenatal appointment due to scheduling, particularly for families with Medicaid insurance. So I guess I'm saying it's not hard to fall into our definition of inadequate or insufficient prenatal care, oftentimes just due to access. Next slide. So we have admission, we have labs, we have an exam, and of course, we always need to talk with families. So as I said, I have the best job, so we always want to sit down, confirm the history, examine, look for any pathology, and more importantly, chat through some education on how to get babies off to the best start. We're always looking out for the sick babies, but then we're also like, how do we help healthy babies get off to a good start, such as breast and chest feeding. In addition to the usual items in this family, we really want to address the marijuana use, and as I stated before, really share that a cord toxicology has been sent. And both hospitals have been through a statewide program with the Illinois Perinatal Quality Collaborative, specifically on opioids, but we have completed stigma and bias training. Our goal is to kindly ask about marijuana, reassure, ask questions, listen. I learned a lot. I've heard of motivational interviewing. I know the standard process with that. I thought that was really helpful with Dr. Weiner's presentation, but hopefully use that technique to talk with families. And then offer information. And really, honestly, at the hospital with the moms, and Beth would probably say the same thing, it is so, and our doulas and everyone, more common than anything else will be, they will share that they are having some mental health issues, whether it's anxiety or depression, and then that is the reason. There's the nausea piece too, but very commonly it's self-treatment of a mental health issue when you sit down and really, really chat about the reasons behind the marijuana use. So when you've opened the conversation, really the main goals are you want to help moms and families, you want to connect them to resources, you want them to have the knowledge of how it can impact their pregnancy, but moving forward, their breastfeeding. And you really just want to make sure they've been provided with all the evidence-based information to guide their own decisions. Next slide. Words matter. So when you are talking with families, and I think most people have learned this as well, but these charts are from an article, Recommended Terminology for Substance Use Disorders in the Care of Children, Adolescents, and Young Adults and Families from Pediatrics of June of 2022. Key principles, really, when talking with families, are to use person-first language. So, for example, instead of saying someone is a drug user, you would say a person with a substance use disorder. Instead of saying drug endangered, a baby, you would say an infant baby born substance exposed. So I think, and when you're talking about substances, which is why we're here, you may be thinking these terms are more applicable to opioid use disorder or cocaine or whatever. And because marijuana is legal, however, it still is a substance and we are still having concerns with effects on babies. So just keeping these terminologies in mind. Next slide. Here are some more examples. So drug abuse a better term would be substance use disorder. And actually, Dr. Tamara Old, if anyone's had the opportunity to hear her speak, she runs the Jolt Center and this is her life's passion. She came and spoke at the hospital and a huge focus of her presentation was on that words matter. Another last example I'll talk about here is just really the concept of the clean and dirty terms. Those are really not appropriate. We would use terms such as in early remission and in sustained remission, considering that this is yeah, so those are not healthy terms to use. Next slide. Another excellent resource on this topic is the Illinois Perinatal Quality Collaborative, which I shared. So this is a statewide collaborative. It's over 80 hospitals participate, and it's on for the perinatal health of moms and babies. And they did a large project on opioid use disorder and its impact on moms and babies, and it was a quality improvement, and we made some really excellent changes moving forward with opioid use disorder. But their website is great, and they have a lot of resources for stigma, bias. They have videos, etc. Next slide. Back to our cute, super awesome, fantastic baby A. So for the hospital stay, she does great. She is breastfeeding. She heads home with mom on day of life 2. We are in Peoria County, so she's referred to the Family Connects home visiting nurse program, and the appointment is made 2 days post-discharge with the pediatrician. Family Connects does do an additional lactation support visit at 5 days of life. Yeah, and the PCP office, because we're on the same electronic medical record, they'll see everything that happened in the hospital, all the testing, communications, discharge summaries. Next slide. So circling back to the toxicology screen that we ordered on the baby. So as I said before, I think one of my purposes here is to kind of demystify from our sides what happens in the hospital to you, and then I try to get an understanding of what happens on your side to take back to the hospital. But so when toxicologies are ordered on babies, and what is that anyways? In general, there's 3 options for testing a newborn. This is an example of a urine panel. This would be the same panel that you would test a mom with for her urine. Next slide. Baby-specific testing most commonly includes meconium, and that's when you send the baby's first black tarry stool. And this is considered the gold standard. Historically, this is what we would send. Next. More recently, a cord toxicology has become much more commonplace. It's much easier to collect and send off. It also looks back 20 weeks. Like meconium or any of these, it does require a chain of command. Specimens are labeled, sealed, handed off from person to person. The website says the turnaround time is 1 to 4 days. With transport, weekends, etc., it's commonly a week. So in the hospital, we rarely have the cord toxicologies back before the baby goes home. They basically take a little 6-inch chunk of cord and they put it in the thing, and that's what they test. So next slide. So we tested this baby, and we 100% should have shared with mom at the hospital that a test was sent, and mom did share that she used marijuana, and hopefully we've had a open supportive conversation about that. But we did test this baby, and was that okay? Should we test? Who do we test? What are the recommendations for testing nationally, Illinois, locally? Next slide. So while testing is indicated, I think ACOG says it best in that red chunk there in the middle in relationship to moms. Routine drug, this is for moms, not babies, but routine urine drug screening is controversial. The American College of Obstetrics and Gynecology, which is ACOG, recommends testing be performed only with the patient's consent, and a positive test not be a deterrent to care, a disqualifier for coverage under publicly funded programs, or the sole factor in determining family separation. So all of this talking, screening, and action should be with the goal in mind of supporting and helping the mom and the baby, and not punitive. So there are really no national or Illinois Department of Public Health standard recommendations of the indications for testing for substances, and I did confirm this with IDPH yesterday. So what most places do is what's called risk-based testing. And the recommendation with that is that each institution makes a list of indications and then consistently proceeds to test their patients for those indications, hopefully without bias. And the American Academy of Pediatrics also discusses risk-based testing. Next slide. Wish I could do this. Do you want to try it and see? Just want to see. Oh, there. I was doing it wrong.
Worth a try.
Yay. Okay, so I'm gonna do this. Okay. Ooh, it's touchy. Okay. So I did want to show you that validated screening tool. Dr. Weiner showed this too, and this is the actual one that both of our hospitals use. It's called the 5P. And so these P's are parents, peers, partner, past, and present. And if there is an indication on this of current substance use, then that would trigger urine toxicology on mom, perhaps with her consent, or a baby toxicology. And then our process is that this should then lead to an expert intervention, which he shared as well, and connecting mom to resources. So a little bit more about this risk-based testing. This algorithm is actually from the Illinois Department of Public Health. And it is their guidance, so it's not that you have to use this, but they do have this algorithm available. And this is really with a heavy focus on withdrawal from opioids. That's what a lot of the more recent work, very visible work in the state has been. So basically, if mom states there's known to take substances during her pregnancy, you would test the baby, or if other risk factors are noted, which is in that upper box on the right, these are called clinical risk factors. Then you would test the baby. So once again, you should be consistent from patient to patient. And at this time, marijuana is still considered a substance to be tested for. At St. Francis, we do follow this practice, and we developed our criteria from published examples. It was really prior to the approval of that IDPH document, but they're really pretty much similar. And you can see our criteria, which is once again that inadequate prenatal care, exhibited signs or symptoms of drug and or alcohol use or withdrawal, maternal drug seeking behavior, repeated use of prescription narcotics, incarceration or previous DCFS referral, Hep B, C, HIV positive, unexplained preterm labor, abruption, IUGI, hypertension, in rehab and or currently on methadone, Subutex, or Suboxone, positive results on the 5P integrated screening tool. When pertinent. Here are two other examples of risk-based testing, just to show you the variability. On the left is the University of North Carolina. So it is a list that looks a little bit different than ours. And I think what was really interesting when I was looking around is the Brigham and Women's one in hospital in Boston. This one is actually specifically for marijuana testing. And there's a couple things on there is that they do report all positive toxicology testing, it must be in Massachusetts, to their Department of Child and Family Services. And then their criteria specifically for marijuana, it goes to show how vague all of this is. I mean, here's the first one. Known heavy use of marijuana throughout pregnancy. So that seems like a vague, I don't know what heavy use is. Poor supports and refusal of supportive services as assessed by hospital social worker. Very vague, right? So this is not straightforward stuff. Back to our hospital. Of the indications for testing that we did, is it Christmas? That sounded like the dinging from the Grinch, didn't it? Right? Anyways, that was a sidetrack, but that was a good one. So back to our hospital, these are the indications along the bottom that prompt us to send a cord toxicology. And we did one of our residents did a scholarly project on this, and so I'm going to be showing some of his data today. But by far, most of our toxicologies were sent for that inadequate prenatal care, and secondly, followed by the positive 5P screen. Sometimes more than one indication was listed for the same patient. For this 1 year period, which was January of 2020 to December of 2020, we tested 307 babies, which was about 16% of our admissions. So what did we find? We found that of those that we tested, 43.5 were positive for cannabinoids. And maybe something else, 39.5 were only cannabinoids. So someone asked the question before about other substances along with that. Yeah, so the vast majority of time, it is marijuana, cannabinoids is by far away our highest positive test. And occasionally there are other things with it, but most times not, is what we saw. So about 7% of our babies from our testing and screening were positive. And honestly, this likely underrepresents the number of exposures. And I got some more data on that to share with you all. So from this same study, we took, kind of looked at those results and said, okay, of the moms that said that they use cannabis, marijuana, the terminologies are confusing, but what did their core toxicology show? So they said, they said, this is what I do. And there was 50 moms, and the only thing they said is, this is what I do. And actually interesting, 17 came back negative. So it was maybe before that 20-week look back or something. 34 were positive for cannabis only. And then there were a couple that had some other things in there. But what was even more interesting is when we looked at the actual core toxicology results that were positive for cannabis only, and we looked back to see why we tested them. Once again, the vast majority was not because they said anything or anybody said anything. It was just for that blanket inadequate prenatal care, which is not uncommon in our community. This is another schematic, and this one's from the United States Drug Testing Laboratory for St. Francis Medical Center specifically. This was July 22 through September 22. So this just came back. We sent off those core toxicologies and they sent back this report for that time frame. And in this time, we tested 13% this time, and 41.8 were positive for THC. So that would be about 6% of babies. So that same 6 to 7%. And then the bottom, this grid is really what happens nationally. So lower percents of THC. However, we don't really know how many babies they tested. It makes me think that other places test more people, so the percentage positive goes down. So that's risk-based testing, and that's what we do, and that's pretty much what's recommended, but there are some places that do universal testing. I know in Cincinnati, they did a large project with that because, it makes sense as far as decreasing bias, but it would increase costs and it would increase burden on social services. And of course it would be a process change, but we don't do universal testing here. All right, baby A is getting older, just like we are, and you all are listening to me up here, but baby A is now 2 weeks old, goes fast, babies grow fast. No concerns, breastfeeding well, normal vital signs, everything's going great. And she's at her physician's office visit and like, yay. And then this is the time when probably that core toxicology would come back to the pediatrician. So this would be the time in the physician's office where they would discuss that. This is an example of what that looks like when it comes back. So baby A, this was in baby A's chart, and the pediatrician opened it up and saw that. So the cannabinoids were positive. So what does that mean? I mean, we already knew from the maternal history about the marijuana prenatally, but and now we have this test as well. So what does that mean for state law, reporting, follow-up, baby's health? And this is what I learned in my review for this talk. Laws for substance use disorder across the nation are crazy in how much they vary. Each state has different laws. So you can tell the red boxes are the number of states that adhere to whatever is listed next to it. So you can see 24 states have no specific laws. And then you've got Minnesota, which supports risk-based testing. It defines substance use during pregnancy as child abuse and grounds for civil commitment. So some states are like, you're off to treatment, or at least that's what their law says. I don't know if that's actually what happens. Yeah, and then, you know, Illinois and 4 other states say substance use during pregnancy is child abuse and healthcare workers must report to DCFS. So that is what happens in our hospitals. For substances, that's substance use in general. In Illinois anyways, marijuana is not treated the same way. But that's not the same from state to state. So I mean, everybody here, you know, from my experience at the hospital, with marijuana, there's no report to DCFS, and that's in Illinois. And then, as I learned a lot, is this, the APOR system. So that is another report that occurs for a positive marijuana test. So as I said, Illinois, there's no report, but when you look, I did not look at all the states. That would have taken a lot of time, but I did find a few. I know Colorado does report, and I already saw that Massachusetts does report for marijuana. I don't know what happens, but okay, so for me, demystifying the APOR system, which is the Adverse Pregnancy Outcomes Reporting System, which I know many people in this room are very well versed with. So appreciate any feedback on that. But so from what I learned, and this will be helpful for me to take back to my hospital people and our OBs and pediatricians so they understand what happens on the other side of this coin, is that they collect information on Illinois infants born with birth defects or abnormal conditions to survey, guide public policy, refer children. It started in 1988, and the licensed hospitals must report within 7 days of birth. And I saw that data because I sat with our abstractor, Linda Blackard, and she showed me they actually do track that. You need to have that in by 7 days.
Mm-hmm.
I think they published who doesn't get it in or something. She was proud. Ours was pretty good. I think they did points this good too, so. And then to be reported, entered, I guess entered maybe, it's not like it's a punitive thing. To be entered in the APOR system as a case, you have to meet one of the following criteria, a baby being less than 31 weeks, part of a triplet or higher order birth, having a positive drug toxicity, signs of withdrawal, or a mother admitting to using it as illegal drug, or any congenital anomalies, or a neonatal or fetal death. Okay, sorry for everyone online for that. So this is the same information, but more in a grid format. And I couldn't find a more up-to-date one, but initially marijuana was excluded in the substances, and then it was added in March, which is why we're here, as you shared.
Yeah.
So this had a massive impact on the health departments that are doing this high-risk infant follow-up programs. So thank you to the Tazewell County Health Department. You know, I know this was a force driving, bringing this conference together. So with the marijuana piece, who gets included from the hospital side? It's that same list where they talked about substance use. So a positive toxicology, if the mom admits to use during pregnancy, if there's signs of drug toxicity or withdrawal in the infant,